Hello, good morning, everybody. Welcome to the next episode of the Health System Fix podcast. My name is Dr. Gaurav Mishra. My guest today is Sonia Tucker. Sonia is the Vice President of Population Health for San Ysidro Health. She's also a physician trained in Venezuela, and she's practiced there for many years and also holds an MBA. Welcome, Sonia.
Nice to see you, Dr. Mishra.
Tell me a little bit about your life growing up. What was that like?
Oh my gosh, that's interesting. You know what? Interesting enough, I'm one of 5 siblings and I'm the oldest girl. I was born and raised in Venezuela, grew up in a very sort of a rural area. My dad is a civil engineer. My mom is a homemaker. But in the area where I was born and raised, it is very agricultural. So everybody know whether you were a doctor, an engineer, architect, whatever it is that you were doing, you ended up owning land and doing agricultural work. So I grew up with both of my parents, my mom and dad, working in lands that we had. I grew up in a tiny little town that's called the Twin Cities. As the older girl, I had a lot of responsibilities because in my culture, you're the elder, the one that usually carries the responsibility for your younger siblings. And being the girl, that is what's expected in my culture. But I had a really happy childhood. We used to go to the farm and I learned a lot about crops and farming. And, if we had to work, we had to like roll our sleeves and do it. And I did work in the farm during the time that I was off from medical school on vacation. So I would go with my mom. And so I was very aware of the area, which interesting enough, I ended up working in that area when I became a physician and loved and miss my country very much, I have to say.
Tell me about the inspiration to go into medicine.
Okay, so my family are very numbers driven. My dad an engineer, my grandfather was a math professor. My uncle was a math professor as well at the university. So my parents were immigrants in the country where I was born and raised. So it was expected that I was going to go to some kind of numbers. When I said, hey, Dad, I'm going to go to medical school, my dad was like, you are what? So the reason why I decided that medical school was the right path for me was, well, first of all, and I know it sounds cliche, I love helping people. So that's something that I identify with. How do I help people? My idea was more than just helping people, change systems. So my dad had his first heart attack when he was 33. I was about 7 years old. I noticed that there was not so much prevention, especially at that time, even though my dad was, for the most part, 33-year-old, healthier, used to play sports, and having a heart attack and not really having enough knowledge on how he could have prevented that. So after that heart attack, my dad also had started gaining weight, couldn't be as active as he was before. And then his liver started being affected. So he had steatosis. And I kept just thinking, well, there has to be something that we can do, but nobody seems to have given him the education, the option. So that was basically my motivation because I didn't want another person like my dad. So that's why I decided to go to medical school and really try to change systems. So I never thought about one person. I was like, okay, we need to change this. We need to do preventions.
Was recently speaking to somebody about healthcare in Cuba, and there's a lot of community engagement. Now, in your role, you're overseeing case management, ECM. Thinking back during your time working in Venezuela, how was the use of community health workers?
When I went to medical school, interesting enough, I ended up working in underserved communities just the same way. That's how I gravitate. And I use a lot of community health workers as I worked in the rural areas. And we had to, because there was very few of us, physicians and nurses, but there was a lot of community engagement. And by the way, the community health worker, I call them Dr. La Vecina, which is like the neighbor doctor, because it's usually the lady that really is aware because they had no doctors in those areas. So they became kind of the advisors for the community. So when I worked in the rural area, I depend a lot on them because sometimes, especially during the weekends, it was me. That was it. And the community was very tight, but also very broad. in broad meaning like they were small pockets of communities in areas where that it was hard to get. So sometimes it would take me 2-3 hours to go to the community, and our closest hospital would have been an hour, 2 hours away in a private car. So we really did a lot of community education, community engagement, working with community health workers to really empower them to do the education and the prevention in the community. So it was something I saw it more on the rural areas, not so much on the cities where I went to medical school. But we tried getting into those pockets on those cities to really work with those communities and the people that they trust. Not because we were doctors that people, "Oh, let me just trust this unknown person." And I love doing that. I remember going to the high schools and doing that education with the younger people and really empowering them to do that.
So these community health workers, were they members of the community who were engaging with the medical system, or they were members of the medical system like we do here?
There were members of the community that had the best interests of the community in mind. So what we did, at least for me, is we engaged them to work with us and really bring them alongside us. It wasn't what we wanted to do as doctors, because what may have been a priority for me might not have been a priority for the community. And in fact, I have a very interesting story, because I wanted to make sure that we were drinking the clean water, that we were getting vaccinated. And for them was more like, so how can we eat healthier with what we have? Yes, vaccines were important for them, but before that, please help us understand how we can get to a healthier level with what we have, with the resources we have, knowing that we are 2 hours away from a hospital. So understanding, working with them, for the most part, community leaders, women matriarchs in the community, basically. And so what I used to do with them was meeting with them, understanding what was their needs and how we could meet it. And maybe for me to tell them, hey, I would like to look at vaccinations, or I would like to look at being active. It wasn't necessarily, oh, they were part of the community health center. Totally opposite. They were part of the community, and we brought them into the community health center.
You worked in Venezuela for many years as a physician. What was the transition like for you coming to the U.S.?
I think we kind of meet in that place, Dr. Mishra. I think there is a lot of talent in the United States, foreign doctors that come to this country. First of all, is a huge change, because you have to learn the system first and really go through all your training as well. In many cases, people are highly trained, come from other countries, and then they have to go back to residency. But before going back to residency, you have to take all your tests. A lot of people do get discouraged. But what I want to say to people that might be hearing is like, you know what? Medicine is beautiful, and it's very big, and it's very broad. So how can we use in the United States the talents that we have to really impact systems, if that is what we want to do? For a while, I want to be able to prescribe, and then there is a beautiful thing in here, is like the knowledge that we get from being trained in other countries. It doesn't go away. Maybe your license is not transferable to the United States, but you have the knowledge, you have the passion, and you have the willingness to really work on areas that you want to impact. So kind of opened my eyes when I came to the United States, where I said, wait, I went to medical school to change systems. I want to make an impact on the systems, not only on my dad, for example. So how can I use my knowledge and my passion to really get to that point? So I started taking my boards, and I took step one and I passed it, and then I had kids, and then the time went by, and I'm like, I don't think I want to do this, and I don't know if by getting a license for me would mean that I'm going to accomplish what I was set to accomplish. Thankfully, I ran into a friend of mine that used to do medical mission trips to other countries, and I was learning the system in the United States. And in fact, when I came here, I was the patient of a community health center. So And I started looking at community health centers and how they work. And then I met this doctor who really inspired me a lot. And then I met an administrator who is now 80 years old, who was a magnificent lady. And I said, wait a second, I think this is what I was set up to be, is really making the change on systems. I have a medical knowledge. I don't need a license to prescribe because that's not going to change systems if I prescribe. So let me see what I can do. And I started working. The system in the United States is very complicated. Having practiced medicine in other countries, I have to say that I wish we can bring some of that red tape down. But at the same time, I also get that we're big and we have to be very conscientious of liabilities and whatnot. It was a learning curve, but I ended up, understanding that this is where I wanted to be, and I had been able to do something for societies.
Also, from your story, I'm hearing a lot of population health work was already part of your training from very early on back in Venezuela. Jumping ahead, you did a lot of amazing work during COVID-19 across the San Diego County. Can you tell us a little bit about that work?
I can tell you right now that, and especially because I also do risk management and I am very aware of all the regulations, but COVID-19 was such a unique time that I think we were just making it as we go. Remember, I used to work at a different community health center, which I'm very, very grateful to that community health center. It really taught me everything I know. I remember it was the late of March and we are listening to this flu that is crazy. And then all of a sudden we get a call from our CMO and our CEO saying, well, it looks like we're going to have to shut down. And it was a small group of us. And I remember we were in the HR department. And I said, what do you mean we're going to have to shut down? This community health center is located in a very interesting area in San Diego County. It is, there is a lot of refugee population in that area. And I worked there for over a decade. So what I realized was that a lot of the patients in that area were not going to leave the area because they've never left the area. They immigrated from their country to the United States and they felt comfortable in there. But as soon as you got them out of their perimeters where they were comfortable, it was very difficult for them. And you being a psychiatrist, you know that a lot of them come with PTSD because they're refugees. I felt I had worked already with them, so I knew that it was going to be difficult. So I remember having this conversation can't close. We have to stay open. The CEO, who is from the area, and the CMO were like, you're absolutely right, but how do we do this? And I said, well, we do it one day at a time. It wasn't Sonia's decision, but I really wanted to stay open. So we did what a lot of people did. We went down to a skeleton crew and we stayed open. And I remember it was one day at a time. I remember we did a whole setup in the back of the main clinic and we were scanning patients for symptoms and taking the temperature. And I remember when I said, hey, we have this building next to us, and that building, we need to be able to treat patients with upper respiratory symptoms. Why don't we use that building? Guess what? That building had no license, no permits, not anything. But I talked to the CMO and I said, we need to be able to segregate the community, the ones with upper respiratory syndromes and the elderly population that comes for their refill of the medication because we need to be there. Thankfully, at the time, I've been working with technology for a while. We already had telemedicine. A lot of people came to telemedicine for COVID-19. We had been doing telemedicine for quite some time, for about 5 to 7 years before that. So I remember one of the things that I now think about is we opened a clinic without a license and we started seeing patients in that clinic, but it worked out really well. And I remember talking to the compliance person and say, can you get us a license, please? And that was after and the CMO was like, Sonia, we're going to get in trouble. I said, listen, we'll ask for forgiveness instead of permission because we might not get the permission. Our patient population need us. So we started working with the county. In fact, I think we opened that clinic the following day or 2 days after. We were one of the first clinic to have a COVID-19 test, the rapid test, because I don't know if you remember, but back at the time, sometimes it would take a week, 2 weeks before we hear back if the person had COVID. we had the test that would tell us within minutes, and it ended up really helping that community a lot. And I have to say, I was very proud of what we were able to accomplish. Everybody was hands on. Let's do this for the community, not for us, because we were all exposed to COVID. The last thing you wanted was to be exposed to COVID. There was no PPE. I remember just working with the PPE we had, but we were able to really take care of that area with the resources we had. I learned more than what I cared to know about COVID-19, but I also learned tons about infection control and prevention and airborne diseases and so forth. It was stressful, but it was very fulfilling to be able to bring to the community what the community needed and deserved at that particular.
I don't know. I don't know if you relate to this. For me, somehow at time of crisis, my brain seems to work better. Sounds like that is very similar for you. Like
I sometimes when the stress was like, okay, my brain is clear. This is what we need to do. And for me, going back to your initial question, this is what I went to medical school for. So I have two kids at the time. They were in high school and middle school, and my younger son has asthma. So what I did was I was like, okay, I went to medical school to help this, to really work on systems. This is a system problem that we have. I moved out of my house. I went to live by myself for a month, left my husband and my kids so that I wouldn't bring COVID to my kid, especially my younger son who has asthma, because we didn't know anything about it until it had a little bit more knowledge. And I felt like, okay, so I think it is difficult, but not impossible to do it. So I'm able to go back home. So it took me, I went back to my house right the weekend before Mother's Day in May to be with my family. I was part of the coalition. There were meetings almost daily for COVID with the counties, with the CDC. So I participated in a lot of those meetings because we wanted to make sure that the systems were in place for the patients that needed it.
Like a more recent project. So AI-enabled diabetic retinopathy screening. But I'm very curious about implementation of this very innovative screening technique within a health system.
Well, I told you I love technology. I never went to medical school to say, I am going to do technology. But as I've moved in my career, God has put me in the places where I've been able to use the different tools that have been given to me to be able to accomplish what was my goal, change his system. And how can we be more effective as a system, as a healthcare system? Well, first, I love what AI is. It's like, okay, it's such a innovative things, but I am a firm believer that we shouldn't use technologies just for the heck of it or because it is the new buzzword, but does it help you as a clinician to be more effective? Does it help the patient to possibly get an earlier diagnosis? That was the bottom line. So I remember working with one of my coworkers, and she does all the research. And initially, we were thinking about the possibility to develop other AI technology for diabetes. I have a very personal interest in diabetes. My dad developed diabetes later in life, and so I'm able to see what diabetes really do to patients, especially when they're non-compliant. So during that conversation with her, she said, okay, so from the population health management perspective, what do you need to do? I said, hey, let me just get into our EMR. And so I pulled the numbers. I said, okay, how many diabetics do we have? What is the screening retinopathy compliance rate? What are the diagnoses? Where are these patients located? We have to figure out what is the problem that we're trying to solve. If technology is an option for anybody, you have to identify your problem. And I remember hearing from a lot of our providers, well, we don't know because we don't get the results back from the eye specialist, or the patient didn't go to the eye specialist. We don't know what's happening. So keep in mind that our patients, until they don't feel a symptom, they're not going to go. So prevention is still a lot of work that we need to do around in regards to educating our patients. But if you think about a diabetic patient has to come to the primary care doctor, at least 2-3 times a year. They have to make sure if they're using insulin, they have to pick themselves all the time. They might have to go to an endocrinologist. They have to go to the pharmacist. A lot of work. If they see fine, the last thing they want is to have a screening in their eyes. In our conversation with the research department, I said, I think we have something here. We have a problem. We have a compliance rate that is a problem. We have increased number of diabetic patients. How can we put those two together? And so we started researching technology. So this was a grant through Cárcel Permanente. So we started to look at what the problem we were trying to solve. And, we vetted 3 different solutions, and we use is a company that's called iNoc. And keep in mind that these are machine learning AI technologies. So was it taught on the patient population in San Diego County, in the East County, in the central county? What are they trained on? What we wanted to do was to really bring the patients to compliance and give the provider a tool that will allow the provider to send the patient to the correct level of care. So the technology doesn't tell you you have diabetic retinopathy. No, the technology tells you there is a possibility that you have diabetic retinopathy. Keep in mind that our patients were sent to the optometrist, and then to the ophthalmology, and then an expert in retinopathies in retinopathy. So there was a third referral. So sometimes our patient was referred 3 times. By the time the patient got to the second doctor, the chances that the patient wasn't going to go was high. So we were trying to really address the fact that we were spending a lot as a system in the United States. You're spending a lot more money because you're sending these patients to possibly 3 different levels of care. So what we wanted to do was, how can we get it from the primary care doctor to where the patient needs to go, which is maybe the eye specialist for diabetes retinopathy. And so that's what we were able to accomplish. We proved that the technology works.
And because I know the kind of work it takes to actually do this, the AI is the easier piece of the innovation, the care navigation that you created here. That is the real challenge within most of our health systems.
But you know what was more interesting, Dr. Mishra, was the fact that we also pair education with the technology. We work with our health education department, and they already work with diabetic patients. So what we did is we added one more session on eye health. It was amazing to see when you give something tangible to a patient. They don't know what the picture of the eye is going to look like, but it's something tangible that it tells you, hey, pay attention. You might you might have a problem. Then you have a health educator, could be possibly a community health worker that you train. And you can say, you can spend some time with this patient explaining to them why it's important that they follow up. Our compliance rate for that cohort is about 80% compared to the 35% that we had with the regular care.
There is so much value to informed consent. Beyond informed consent, it's actually partnered consent, right? We are going to do this together. It may be slightly experimental, but we are in this together. I think that has so much value.
It's exactly right.
They obviously are overseeing quality, right, for a large health center. So sometimes the quality metrics that a health center is tracking is not fully aligned with the quality metrics that would show great patient outcome. Even though that's the purpose of it, sometimes health center tracking is important and it meets the criteria for health center sustainability versus improved life of a patient. How do you think about those two things, and how does it reconcile?
So in community health centers here in the United States, there are 2 sets of metrics that we look into. You're speaking my language. I love that. So, we're talking about HEDIS, which is interesting because HEDIS is not necessarily for us as community health centers or as a providers, that we're not necessarily held accountable from NCQA, which is the organization that really puts those metrics, but they held accountable the health plan. And the health plan puts it on us because the health plans are not providers. So that's one from the Medicaid, Medi-Cal area. And then we have the Medicare, which has some stars, and they also have some metrics. And then we have, for us, community health centers, very unique, is the uniform data system. And that is specifically for community health centers. And so some of those metrics kind of overlap, some other ones don't overlap, so we have to always reconcile that. What I said in regards to quality metrics is we have to always remember that each one of those quality metrics, each one of those numbers represent a patient, and that patient belongs to a family. The reason why I said this is because we have the tendency in quality to get wrapped up on the number. What is the compliance rate? What is this? What is that? I'm like, wait. We need to look at, how really are our patients doing? Because yes, the outcome is important, especially when we are looking at the provider and how is the provider doing? Not because we want to evaluate the provider, but maybe does the provider need more support to be able to do everything that the patient needs? So I think that it has to be a balance between, yes, getting the correct numbers and data, and what is the outcome of that particular patient. So really looking at the system as a whole, because maybe I'm a diabetic patient, and maybe my hemoglobin A1C is controlled and my blood pressure is fine. I might be missing my diabetic retinopathy screening. So how do we really reconcile that information? So I think it's important that we look at the positive outcome and that in the low compliance rate, that we look at that as a possibility for improving the outcome of the patient populations that we're treating. So here in San Ysidro, we look at the compliance rate from different perspective, or the quality improvement from different perspective, from the provider, from the clinic, the region, and as a whole. So we can see, is there a problem in our system that we can potentially address with a system intervention? Maybe it's the provider that needs a little bit more help. And then that's when my population health management hat comes, because we haven't even talked about social drivers of health. Is the outcome related to the social drivers of health because the patient doesn't have transportation, for example? Or is it the patient really doesn't have enough money to buy the food? And so we need to look at that. It's like, it's not only the number, it's what is behind the number that is really giving us the outcome. And there is the technological piece where the system is not picking up the numbers. Yes, sometimes there is data that is left on the system, but don't take the numbers as a face value, because the reality is the numbers is part of a story.
Right. And I think often the story part is left alone. And you're right. I think two patients with, let's say both of them have normal or very high HbA1c, and say those numbers are equal. Outside of those two numbers, their lives could not be more different in every other way. So that number may indicate one thing, but the story behind it is so much bigger.
You're absolutely right. That's why social drivers of health, I think I'm glad that we're shining the light to those kind of stuff, because we have social drivers of health and we have also other areas that we need to take into account. I mean, you're a psychiatrist, what if that patient has a high PHQ-9? Or maybe a GAT7 that is high. So that patient could be doing everything that they can do, and the provider is prescribing, doing everything, but the patient has anxiety, depression, because there's something going on at home. That if we don't do the screening, so we will never know.
I'm working currently on building a comprehensive dementia program. It's still in my head, so it's that's where it lives today. But oftentimes what I found is the patient metrics, the patient individual level metrics, the population health level metrics, those social determinants of health, all of these three metrics oftentimes, unfortunately, live independent of each other, right? Though they can actually enhance each other so much more. Trying to design a new system where like the individual patient metrics, the population health metrics, and maybe social determinants of health, all of these factors are inbuilt within the system, ground up. How can one do that?
Oh, that's a great question, because I go back to the data and the systems and how we need to look at this. And there are ways to analyze data where you can see the relationships between the data. But the first thing that we need to start doing is we need to understand, we need to look at the system. We're not just saying we're going to screen a patient just because it's what the regulation says. What are we trying to accomplish? That's the first thing. We have to identify the problem, right? The problem is potentially that we are not screening our patients in a timely manner, where it is allowing us to really establish some interventions before the dementia progresses. And I have to tell you, I have a very personal story, a family member, where I remember seeing the signs of cognitive decline during COVID. And this is a person that is highly educated, has a PhD. So I remember calling his primary care doctor, and it took a while before the system came to really be at the same level that we were as family members, seeing the cognitive decline of that particular family member. So could we have done something different to really prevent from the dementia from progressing? Maybe. The other part that we need to look at is how can we utilize technology and de-stigmatize so that way our patients really are asking us primary care doctors, hey, I want to know how my cognitive health is. The same way we go for a preventive exam, then we should definitely have a multi-level data analysis where we have the patient's age, so demographic information, but also we have these social drivers of health. And we need to see, according to the social drivers of health, what is contributing, or maybe do some predictive analytics to say, okay, what is the possibility of this particular patient developing cognitive decline? What are we going to do? Because it's not enough that we're going to screen. What interventions are we going to draft to make sure that the patient understands that what we're going to do? So I think it's magnificent. I love the idea. I would love to hear more about your idea. Always think about technology, doctor. How can we make this available for everybody that is at a certain age or has certain characteristics, so that way we can empower our patients to do that?
Maybe a quick thought on what about metrics that are personal to individual people? I feel like there is a level of engagement that a patient has when they're extremely sick. And then there are patients who are mild and moderately ill, and their engagement is different. Rightfully so, because the need urgency is different. But then I think, can we in healthcare do better job of capturing the person level metric that is just important to that one person? And have you seen that done anywhere? What role that may have?
Interesting you're asking that, because we have tons of data at our fingertips now with electronic health records. The health record system that we use at San Ysidro does have that patient level data, and it has some predictive analytics, and now has AI for us to be able to predict what could potentially happen, right? However, I think the question here is, we have it. Are we using it? And if are we using it for what? I can tell you right now that patient level data is not necessarily something that we are, as a healthcare system, I don't think we're taking advantage of it. We don't have a system where we can say, hey, okay, Sonia, she is a 50-year-old female, for the most part healthy. Here is the no-show rate in her past. This is her engagement rate. What is the likelihood that Sonia is going to go get her mammogram done? However, the issue I think that we have here, it depends on how big your population is. I would say if you have a population that if your practice is small enough that you can do this, it will be very, very magnificent, because you can put all of us into groups. Like, Sonia has the 50% chance that she's not going to get her mammogram done this year because she's healthy for the most part, doesn't have any past medical history or family history of breast cancer. Sonia's going to get her mammogram every 5 years, or if she finds a lump in her breast, right? There are many Sonias in the world. What are the possible interventions that we can have with those? With that particular group. So again, the data is available. How do we use the data is what's interesting. So we're looking at the prediction of the no-show rate of that particular patient, and do we add one more reminder in a different modality so that the patient were to come? But I think there's a lot we can do in that area. The more we collect social drivers of health, the more information we're going to have. And I predict in about 10 years, we will be able to see, okay, so patients with these drivers of health not met, we're going to have interventions for diabetes and hypertension different than the ones that have.
And also, I think difference in their experience in their everyday life, going from PHQ 9 to 10, it really matters to us as a health center and as a clinician. It may not change the patient's experience as much. Like, can we capture the patient experience beyond those numbers, which can then engage them better?
That's a great point. It will be interesting to see, what is the patient experience compared to compliance rate, SDOH? That's something I have not done. Now you got me thinking.
Last couple of questions for you. We have a lot of amazing physicians trained outside of the U.S. I know many of them working at San Ysidro, many of them working across health centers in the U.S. If you have some advice for somebody who's early in that stage of transition.
I do have an advice, and I've tried to mentor some of them. I would say be open. That's the first thing. Healthcare in the United States is complex, big, but very rewarding. You have a knowledge that nobody's going to be able to take it away from you, even if you don't have a license. So figure out why is the reason why you went to medical school. In a lot of our countries, we don't necessarily have an opportunity to develop systems or to look at the healthcare as a system unless you work for the government. And in reality, in the United States, there is a lot more opportunities for that. So if the reason why you went to medical school was because you want to do research or because you want to change systems or because you want to develop programs, that is something that you need to think about and be aware that you can do that here without necessarily having to go back to do all your boards. Now, if what you want is really take your boards and become a licensed provider in the United States, I think you have to really prioritize your time correctly, because it will be very difficult, not impossible, if you're working full time and really get a good grade in your boards, because you can pass your board, but and then it will be very difficult for you to match into a residency program. I do have a request for the American Medical Associations. Take a look at the real skills that some of these people really have, because I think United States puts a lot of red tape on areas that shouldn't be red tape, and we have shortage of clinicians in areas that these people could potentially be helpful at. How can we develop a system where we take advantage of that knowledge in that power that those foreign trained physicians bring to meet the gaps that we have in the system?
Last question is, what is the most exciting or challenging problem you're working on today?
That is interesting. Great question. Well, I think my days are really, really exciting. But something that we're working on today is we want to move as an organization from being reactive to being proactive. And so I work a lot, and Dr. Misha, you and I work very closely together. We miss you very much in our MSQRC, our multi-specialty quality review committee. So we have taken that group to, okay, we got a problem now is, let's look at our system to see if we can identify possible areas of improvement or gaps that haven't been a problem yet, so that way we can address them before they become a problem. I think that's the most exciting part that we're working on. Some people will say, what? You're looking for problems so that you can have more work? But what I want is, because, I was a community health center patient. My mom is a community health center patient. So I want us to create systems that are effective, that brings health equity, that they're safe, and that our patients feel like they belong to. So, and that our providers feel like I'm working from the top of my license and administration has my back on this. So that's basically what I want to do. And I'm excited because I had like 3-hour meeting yesterday. I'm like, oh, we need to look at this part. We need to look at this part. Let's see what we can do. The board is like, Sonia, you like to do this? And I'm like, apparently I do.
That's also a sign of a great leader. What he said is that without a good team, we cannot do any of the work that needs to get done. Yeah, it definitely was. I have fond memories of being in that MSQRC meeting in the past, so I definitely miss it. Thank you so much, Sonia. I appreciate you joining us today. It was really exciting talking to you again.
Nice to see you, Dr. Misha. We miss you a lot, and please don't be stranger. Keep in touch. Let's work on something fun together.
Absolutely. Thank you.
Bye-bye.